Good morning, everybody. After the excellent dinner and dancing and singing yesterday, it's time to restart the lecture. So today we're starting with a focus on from basic topics to clinical epidemiology. Co-chair with me, Borja Ibáñez, that's at the CENIC, and also Fundación Jiménez Díaz, and myself, Toni Bayés-Genís, in Hospital Germans Trias in Barcelona. So we have two fantastic speakers this morning that are going to cover different aspects from basic to clinical epidemiologist. Let me introduce first Roberto Elosua, who's going to talk us about genetics and coronary heart disease. Roberto is working at IMIM, Investigació Municipal d'Investigacions Mèdiques in Barcelona, and he has a double background, the background of epidemiology and the background of genetics, and he has been a member, or probably I would say is a founding father, one of the founding fathers of the main consortia for genetic and coronary artery disease. So Roberto, it's your turn.
Thank you. Thanks, Tony, for the presentation, and thanks to the Spanish Society of Cardiology for inviting me to this symposium. First, I have to disclose that our group is working with a company evaluating the role of genetic testing in cardiovascular risk assessment. And second, this is the highlights of my presentation today. The focus is genetics and coronary heart disease, and when I try to think about how to transmit most of the knowledge on genetics of coronary heart disease, I thought, well, we need to have some basic concepts to avoid a classic paradigm when we talk about genetics, that there is a lack or a different language, a very difficult communication between geneticists and other specialists such as cardiologists or epidemiologists or in general clinicians. So I'll try to review some of the very basic concepts related to genetics. Probably most of you are aware and know about that, about this concept, but yes, let me use a few minutes to review some of these ideas. So all of you know that genetic information is contained in a molecule that is the DNA. This DNA is in all the cells in the nucleus of all our cells, and the genetic information is based on a code, on a sequence of nucleotides, of letters, that determine the synthesis of RNA, and this RNA also, with the combination of three of these nucleotides, determine the incorporation of an amino acid in the synthesis of the proteins. So this genetic code serves as the basis for the synthesis of the different proteins that are working in our bodies. And this is the classic view of genetics. So let's say that we have person 1 here with this sequence of nucleotides in his or her DNA, and this is the most common sequence in the population, and this sequence determines the incorporation of these amino acids in the protein that is being synthesized. We have another person 2, that has a different sequence of nucleotides. And in the third one, in the third position, instead of having an A, this second person has a J. And sometimes these changes in the nucleotides do not imply a change in the amino acid that is being incorporated in the synthesis of the protein. So these two persons have a different genetic code, but the protein that they have or they are synthesizing is exactly the same. So we call to these variations synonymous variations. But we have another person that has also just a single change in this sequence, in the 5th position. And this change in the genetic code does imply a change in the sequence of the protein that is being synthesized. So, and this protein could be different to the most common one, and this difference could work, that this protein could work better, gain of function, or could work worse, a loss of function. And when we talk about these genetic changes, we can use, and geneticists use different words, and this is confusing for us. So they can talk about sequence variation, genetic variance, polymorphism, single nucleotide polymorphism, and they use also this RS and a number to identify one or each of these genetic variants that are located in different parts, in different locus of the genome. So I will use, in a general sense, the genetic variant term, and when during this presentation, when I use genetic variant, I will refer mostly to these changes in just one single nucleotide in a single locus, in a single position in the genome. So the second important thing to know is when we try to tackle and to identify what is the genetic background of a disease, we have two different two very different approaches. The first one is when we try to identify the genetic basis of Mendelian diseases, and these diseases are mainly related to one gene or a few number of genes that have a huge impact on the disease. And a clear example of this is familial hypercholesterolemia. And on the other side, we have complex diseases that are related to not just one gene, but a lot of different genes. And in these genes, a lot of different genetic variants. And in the definition of the individual susceptibility to present this disease, genetic is important, but environment is also very, very important. And a clear example of these complex diseases is coronary heart disease, and we are going to focus on coronary heart disease today. So what we know right now about the genetic of coronary heart disease? The first thing to answer, or to answer, is to see if genetic is important for coronary heart disease. And you will say, yes, it's important because in our experience, family history plays a role. But can we identify the proportion of the relevance of genetics and quantify this relevance? And to quantify that relevance, we can use a statistic that is called heritability. And heritability provides us with information about the proportion of the phenotypic variance that is explained or attributable to genetic variants at the population level. And this is important, at the population level. And in the case of coronary heart disease or atherosclerosis in a more broad sense, there are different studies, and most of them the range goes from 40% to 55%. So, wow, a huge or a significant proportion of the risk of coronary heart disease is related to genetics. So it's worth to work and try to identify what is the genetic background of coronary heart disease. How can we identify the genes and the genetic variants that are related to coronary heart disease? A hallmark study was one study that is called HapMap, And this study just shows us that each of these lines is a genetic variant. And this study shows us that the genetic variants are associated and are present in blocks. Geneticists use linkage disequilibrium. For us, it's just association. So if you have a genetic variant here, you probably have another genetic variant in this other locus or loci that are present in this block. And in this smaller block, the genetic variants are also associated, and the same in this one, and the same in this one. So if we want to study this segment of the DNA that reports this type of information, the house has a red door, we don't need to know all the letters. We just need to pick up some of them, and we can guess what is the genetic variability of all these segments of the genome. So using this approach, we have been working in genome-wide association studies. These studies look at the samples that we are working, 60,000 cases and more than 125,000 controls to identify the genetic basis of coronary heart disease. These are huge international consortiums. This has been a huge experience and a huge opportunity to collaborate across different groups across the world. And we can use some chips that are commercially available, and we can obtain information about 9 million of genetic variants across the genome per individual, if the genetic variance is present or not. And with this approach, that is a hypothesis-free approach, we have identified almost 60 loci associated with coronary heart disease. A very important thing to know is that each of these loci has a very small effect. The odds ratios for these genetic variants ranges between 1.1 and 1.2, 1.25. So very small effects for these genetic variants. And all these genetic variants explains around 15% of the heritability of coronary heart disease. So still, there is a lot of room to discover in this field. And and these are the loci and the genes that are in these loci, in these almost 60 loci. The most significant is located in chromosome 9, 9p21. There is no gene there. We don't know what is going on there. And let me show you some other actors that you well know, such as LDL receptor and the well-known PCSK9 that has been discovered using this approach. This approach also serves us to know the main pathogenic pathways related to coronary heart disease. And these pathways are lipids, inflammation, and immunity. These are the main pathogenic pathways related to coronary heart disease. So, and the new studies that are coming up in the last 2 years, there have been some of them, 4 of them, are the sequencing, just not genotyping or determining some of these genetic variants, just reading the whole genome, the whole sequence of letters. And these studies have also identified new genes and just retain this one, ANG PTL4, because we will talk about this later. So the main focus of this roundtable is just from basic to the clinics. So what are the clinical utilities of this information? And I will focus on these 3: cardiovascular risk estimation, identification of new targets, and pharmacogenetics, pharmacogenomics. And, well, cardiovascular risk estimation, you can say, well, how a genetic variant that it has a so small effect, 1.1, 1.2, could be useful for prediction, and you are right. But we can combine all the genetic information, all the information related or coming from these almost 60 loci in one single score, what is called the genetic risk score. And this provides us with a effect size or effect sizes that are much bigger. You can compare this group with a high genetic risk score compared with the median, and the odds ratio is almost 2, so double the risk. And you can see that this group with a low genetic risk score compared with the median has half of the risk, an odds ratio of 0.5. So when combining all this information, we are getting effect sizes that are much bigger and could be useful for prediction or improving the prediction. And this has been done by different studies. And here you have a summary of these results. All of them report an association between the genetic information and the risk, but this is not enough. Association is not enough for prediction. We need to improve discrimination or improve reclassification. Well, genetic information does not improve discrimination, but it does improve reclassification, mainly in the group with intermediate risk, that is the most interesting target from the clinical point of view, because we don't know very much what to do with this intermediate risk group. So genetics can have a role here. Let me focus on this part of the slide of the table, secondary prevention in patients with the disease. Genetics plays a role. Well, at least at this moment we know that genetics is associated with a worse prognosis in these patients, in patients with the disease. So, well, let's see it also in the future if it helps in improving discrimination or reclassification. But more interestingly, in this paper published last year by Mega et al., analyzing some clinical trials in primary and secondary prevention, they show us that the efficacy of statins, the higher the genetic risk, the higher the benefits of statins. So, and this is also an important piece of information to have in mind. So, the second clinical utility that I mentioned was identification of therapeutic targets. And one approach that we can use is the approach that is called Mendelian Randomization. What is this Mendelian Randomization? This approach is very useful to assess if the association between a biomarker and a disease is causal or not. And why this is important? Because if this association is causal, we can target this biomarker to prevent the disease. If this association is not causal, if we target this biomarker, it won't affect the incidence of the disease. So, and this approach was proposed in the late 80s by Kattan et al. And there was a discussion at that moment about the role of low cholesterol as a causal factor for cancer. And they said, well, if low cholesterol is causally associated with cancer, so we know that there are some genetic variants that are associated with low cholesterol levels. And if this is causally associated, this genetic variant should also be associated with the disease. And this was the approach. If this is true, the association between low cholesterol and cancer supports the causality of this association. If this is not true, if this genetic variant is not associated with cancer, this fact does not support the causal association between biomarker and disease. And this association could be reversal causality, so it's not a cause, it's a consequence, or reflects that this association is mediated by a third factor, another factor that could be the causal mediator of this association. So we use this approach to assess if HDL cholesterol is causally associated with the disease, with coronary heart disease. And we identified a genetic variant that was associated with higher levels of HDL cholesterol in different cohorts. And we thought, well, if this genetic variant is associated with higher risk, with higher levels of HDL cholesterol, and HDL cholesterol is causally associated with the disease, this genetic variant should also be associated with lower risk of coronary heart disease. And we analyzed this in different cohorts, and we did see any association, questioning the causal association between HDL and coronary heart disease. And all of you know that previous experimental studies have reported that CETP inhibitors are effective to increase HDL levels, but they are not effective to decrease the incidence of coronary or cardiovascular events. Another example, the second one, you know this one, PCSK9, was identified in 2003. 2003, not, yes, not well, yeah, just 12 years ago, and was identified to be associated with familial hypercholesterolemia. We also show that the genetic variants in this gene were associated with lower risk of coronary heart disease, supporting some causality there. And you also know that we have some drugs right now in the market that are very effective to decrease LDL cholesterol, and preliminary data suggest also that they are effective to reduce the incidence of cardiovascular events. So, a nice story here. And another story, the third one, and the last one for therapeutic targets, ANGPTL4. It's a new one. It was just published 3 weeks ago in the New England Journal of Medicine. This protein, this ANGPTL4, blocks the activity of lipoprotein lipase and increase triglycerides. So we have also identified a genetic variant in this gene that has a loss of function. So the protein works lower. And we have also seen that this genetic variant is associated with a lower risk of coronary heart disease. So another very interesting therapeutic target in ANGPTL4. And in the same number of the New England Journal, another group just report a new antibody anti this protein that is very effective to decrease triglycerides in animal models, in mice and monkeys. So this is a new drug that probably will come in the near future in clinical trials in humans, and let's see if it's effective to decrease triglycerides and also prevent coronary heart disease, ANGPTL4. So, and the third clinical utility is pharmacogenetics. So, yesterday, Dr. Cranhall was mentioning about this big issue of precision medicine and to identify responders and no responders to a drug. And here we have a very clear example with clopidogrel. You all know that this is a prodrug that should be metabolized in the liver to get the active metabolite. And this metabolization process is done by the cytochrome P450. So there are some genetic variants in this cytochrome that influences and determine the rate of metabolization of clopidogrel. And these genetic variants are associated with worse or better prognosis in patients taking clopidogrel. And there are some scientific societies that propose and support the genotyping of these genetic variants to define the use of clopidogrel in ultra-rapid metabolizers or other alternative therapy in those that are poor metabolizers. So another clinical application of this knowledge. So there are some new areas of research, very interesting. One of them is epigenetics. I will just mention some very basic concepts. Epigenetics is heritable, or refers to heritable changes in gene expression that are not related to changes in the sequence of the DNA. The sequence is the same, but the expression of the gene is different. And this is regulated by epigenetic markers. And a very important issue here is that epigenetic is heritable, but is also modulated by the environment. So we can do a lot here. And let me just put a very silly or simple example of the relevance of the sequence versus sequence and expression. You have this sentence here: a woman without her man is nothing. This has some meaning, but if you express this sequence of letters in another way, you will get a totally different meaning. A woman without hair, man is nothing. So same sequence, totally different meanings. And we have also the same situation in biology. All the cells in our body have the same sequence and the same sequence in our DNA, but the phenotypic expression of these cells is totally different. And this different phenotypic expression or differential expression is regulated by epigenetic markers. So what are these markers? Just to mention, just to have to let you know that these are histones modifications. Histones are the proteins where the DNA is packed. DNA methylation that regulates gene expression, and the non-coding RNAs, microRNAs, long non-coding RNAs, and other types of RNAs that do not code for the synthesis of the proteins, but have a very important role in regulating the expression of the genes. So, to conclude, I will say that coronary heart disease is a very complex disease with multiple actors and interactions between them. Genetic plays an important role in this disease. We know that almost 60 losses have been identified to be associated with coronary heart disease, explaining around 15% of the heritability of the disease. What we know right now, we have identified mostly common genetic variants with a small effect. We have also identified some rare variants, also with a small effect. And we expect that the sequencing of mainly in families with early onset coronary heart disease will provide us with some rare variants with a high effect. We'll see what happens in the next years. We have reviewed some of the clinical implications of this information, and I have also highlighted the role of epigenetics in modulating the information that is contained in this sequence of nucleotides. Just to finish, I think that this, I'm coming from Barcelona, just let me use this tool that Gaudí was using to build up his buildings. This is the catenary of the Sagrada Familia. This is Gaudí's view. And in that moment, this is the view that, or the aspect that the Sagrada Familia will have in 2027. We hope to see that. And this will be, and this is genetics. Genetics will give us the shape and of coronary heart disease, but it's not only the shape. I think that epigenetics could also help us to identify minor details that are very important for the Sagrada Familia building, and also are very important for coronary heart disease. And finally, thanks to the consortium where we are working, that is led by Sek Kathuresan from Boston, and also Chris O'Donnell, that attended one of these meetings in Tarragona some years ago, and also to thank to the people in my group, in the Regicor, and mainly in this field, we are working with Sergi, Sayol, Sisak Subirana, Carla Gavin, and Jaume Marugat. Thank you for your attention.
Thank you very much, Roberto, for this excellent talk. We're going to move to the next presentation, and after the two sessions we can have some discussion if there is some time left. So it's my great pleasure to introduce our second speaker, who is Hans-Erik Bodker, who is coming from Aarhus in Denmark. He's an interventional cardiologist, and also he's a translational researcher who has done a lot of contributions both in preclinical studies and also in clinical studies. So first of all, Hans-Erik is a close friend, so it's my pleasure having him among us. And as you will see during his lecture, he has been deeply involved in the field of infarct size reduction by developing different interventions. He was implicated in a preclinical demonstration of the use of remote conditioning that he will explain today. And also he was the one moving this field into the clinical arena. And in fact, he was the principal investigator of the CONDI-1 trial, who was the very first trial demonstrating a potential beneficial effect of this intervention. And also he's running the CONDI-2 trial, that is a larger trial with hard endpoints as outcome. And it's a pleasure to also to mention that we in Spain, we are participating in his trial, and even some members of this working group of ischemic heart disease are also part of the board of the trial. So Hans-Erik, we are really willing to your presentation.
Thank you very much, Borja, and thank you very much for the invitation. I really enjoyed going here to Málaga. It's my first time here, and I can tell you this is very different from dark and wet and very cold Denmark. So I think I'll get my batteries loaded here. So thank you very much. It's a pleasure for me to present some of our results about ischemic reperfusion injury. Before we go on, I have to declare that I'm a shareholder in Celiges, who constructs a device for remote ischemic conditioning. So what is ischemic injury and reperfusion injury? You all know that when we are exposed to ischemia in the heart deteriorates progressively, temporarily, and if it continues, you will get a very large myocardial infarction. However, if you interrupt the occlusion of the coronary artery, we would expect that the ischemic injury would stop. But unfortunately, it doesn't stop immediately. When you release a number of scavengers, rust products, and so on, you will actually experience the reperfusion injury. Is that something that occurs in real life? Yeah, you can see here from an experimental model, which is from a pig where you have a normal coronary, where you have a normal myocardium. When you expose it to ischemia for 45 minutes, you'll have mitochondrial swelling, lipid drops in the myocardium, and if it continues, it just progresses. However, if you have no reperfusion, this is the myocardial infarction where everything is destroyed. But notice this one. This is 90 minutes of ischemia and 1 minute of reperfusion. You can see the burst that almost destroys the myocardium in that particular case. Now, this is not just one example. Is it more systematic? We studied that in a rat model where we looked upon the extension of the reperfusion injury, and as you can see here, it seems to progress with time when the reperfusion period is extrapolated. You can also see that there is a possibility for intervention with ischemic preconditioning, but I'll come back to that. If we look at it more specifically, we can measure ischemic markers, and this is in a Langendorf model, and therefore we only measured LDH. And you can see here in the initial part of the reperfusion period, you have a very pronounced release of ischemic marker, and then after 45 minutes you have another peak. If we do an intervention by ischemic preconditioning, you can see that particular peak actually decreases. that doesn't prove that we interfere against the reperfusion injury, but if we do it by using other compounds, you can see here that infarct size reduces with ischemic preconditioning, but it also reduces with ischemic postconditioning, and it reduces with cyclosporin, which is another pharmacological agent that can reduce myocardial damage. And we get exactly the same course of the ischemic marker release by these two interventions, and this sort of tells us that something must go on in the reperfusion period and that we can interfere against it. Is this something that is relevant in clinical practice? It might be relevant in acute myocardial infarction, also in elective PCI, in cardiac surgery and cardiac arrest, and also in cardiac ischemic reperfusion injury that might occur with major non-cardiac surgery. But is it of similar importance in real patient life? Why is it important, for instance, in STEMI? And I think I use STEMI as the teaching point because it's more easy here. I also had to include some epidemiology in my talk today because Borja asked me to. And this is a survey that we did in Denmark some years ago where we looked upon the mortality of the acute myocardial infarction over the last 25 years. And as you can see here, this is the acute mortality, meaning within 30 days. And both for men and women, you can see we do pretty good, not only in Denmark, but I think this is the same all over in the Western world. Acute mortality decreases rapidly in patients with acute ST elevation myocardial infarction. The challenge is that if we look at the long-term outcome, and this is the long-term outcome within 1 year, you can see the decrease is somewhat less. And why is that? When more people survive from acute myocardial infarction, more people are prone to get, or the population increases that can get cardiac failure or heart failure after acute myocardial infarction. And this is data from the United States. And as you can see here, mortality actually doesn't decrease in patients with acute myocardial infarction due to heart failure after the infarction. So we still have a challenge here. And what can we do for our patients? We have to have a chain that needs to be initiated when we have a patient with a STEMI. We have to secure immediate reperfusion, and this is done by the logistics, getting the patient directly to the cath lab. When the patients arrive at the cath lab, we have to secure the optimal interventional procedure, including medical treatment, as you can see over here. So the next target might be to avoid the reperfusion injury. And there are different ways to do that, and that's what I'm going to tell you about. Pharmacological interventions, mechanical interventions, post-conditioning and remote conditioning, hypothermia, and even intermittent coronary sinus occlusion, which is a new experimental approach. I'll concentrate on those two initial parts. There are some differences, temporal differences, spatial differences when you do intervention against acute myocardial infarction or ischemia reperfusion injury. When we have ischemia and the reperfusion, you will get an infarction, as I told you. If you had to avoid that, you can do preconditioning before ischemia to modify the reperfusion and the ischemic period and reduce the myocardial infarction. And it can be done by repetitive, short-lasting occlusion of the target organ, the heart, to avoid that. But it can only be done in predictable ischemia. And we most often treat unpredictable ischemia, STEMI. So what do you have to do in this situation? You can use drugs, but the prerequisite that the drug will work is that it is on board when you start reperfusion. So you need to infuse something into the patient before you open the coronary artery. You can also make a temporal change. You can do post-conditioning locally, where you inflate the balloon after primary PCI repetitively for instance, 30 seconds, 1 minute, 2 or 3 times, and then you can reduce myocardial infarction. But you can also do the remote conditioning. And then you apply a blood pressure cuff or device to increase and induce ischemia in the upper arm, and then you can do remote ischemic conditioning, and that leaves the possibility that you can change the temporal and the spatial intervention from the target organ to the heart, and then you can also move the time when you do it, so you can do it in ongoing ischemia, for instance during transportation to primary PCI, or you can do it after the PCI. This is the model that we have actually used in our hospital. Let's go to the pharmacological intervention first. This is cyclosporin. Cyclosporin interferes with the mitochondrial pores to inhibit the opening during reperfusion. And this was introduced by Michel Ovi's group from Lyon. And as you can see here, in their first proof of concept study that was published in 2008, they were actually able to show that when they put cyclosporin on board in the patient before they opened the coronary artery, ischemic marker release was reduced. They also showed in a subgroup of patients that myocardial infarct size was decreased with CMR. Does that translate into something that benefits the patient? It doesn't. These results from the same group was published last year in fall, and as you can see here in clinical outcome, exactly the same with and without cyclosporin. So there are challenges in translating this into a clinical benefit for the patient. There are other compounds that can be used here. Exenatide, which was a GLP-1 analog that we used in the study in Denmark. As you can see here, the curve here represents the area at risk and the infarct size, and for each area at risk in anterior infarction, the infarct size was less with exenatide than without exenatide, demonstrating that it has cardioprotective effect. I also have to say that there are no clinical outcome measures for this, so this is still a proof of concept trial. Our chairman did this study, as you probably already know, the MEDACARD study with metoprolol, published 3 years ago now, and you can also see here there was a clear effect on ischemic marker release by the approach of using metoprolol in the ambulance during transportation to primary PCI. The more recently published study was the early BAMI trial, which was the same concept, but in a lower dose and with temporal differences compared to the MEDACARD trial. So this is a study that showed that there was no effect of beta blockers. I think that the story hasn't been told yet because there are differences and you need to identify what the differences are and what the consequences are. So what about the ischemic preconditioning? The ischemic preconditioning was developed in 1986 by Murray and co-workers, demonstrating that preceding short episodes of myocardial ischemia before sustained ischemia in a dog model was able to reduce infarct size. It was translated into the PCI situation and the CABG situation, showing that anginal score, ST segment shift, and lactate release was reduced during elective PCI, and also biopsies during CABG showed preservation of ATP concept. But as I said before, this method has limitations because it's invasive and it requires that you do the intervention on the target organ, meaning that CABG might be a possibility, PCI might be a possibility, but STEMI is not a possibility. So it hasn't gained much clinical influence. Post-conditioning was more appropriate to use because when you have a catheter in the coronary artery doing balloon and stent implantation, you can do repetitive occlusion of the coronary artery after opening of the coronary artery. And you can see here from Vincent Johansson's group in Atlanta, in a dog model, they were able to show that infarct size reduces, and that was translated into the clinical situation by Ovi's group, again, by reduction of ischemic marker release. So it seems as if post-conditioning, local post-conditioning works. I have to say then that when you go to the CMR data where you measure infarct size, the results are not nearly as clear. And recently at the ACC meeting just a couple of weeks ago, the clinical outcome data were published from the Danish Dynamic 3 trial. And as you can see here, only a very, very moderate effect of ischemic post-conditioning, not significant, indicating that this is not something that seems to benefit the patient. So what about remote ischemic preconditioning? It was introduced by a Prusklink group in the United States, also in a dog model, where they occluded the circumflex artery and induced a myocardial infarction in the LAD area. And they were actually able to demonstrate that it was possible to reduce infarct size by that procedure. Then it was translated into a situation where you didn't do it within the heart, but used another organ as the effector organ, namely the upper arm. And Hausenloy demonstrated in patients undergoing CABG that doing upper limb occlusion was actually able to reduce troponin release after and during CABG operation. So it seems as if it has a clinical cardioprotective effect. We used the same concept and we developed it further to do that, what we call the perconditioning, because we did that during ongoing ischemia. And we started in a pig model where we were able to show that infarct size reduces when we occluded the hind lip of the pig at the same time as the pig had a anterior myocardial infarction. And we then went on to the clinical situation and applied a blood pressure curve during transportation to primary PCI and inflated it 4 times for 5 minutes with interruption. And we were able to show by SPECT that salvage index was actually increased by doing that procedure. But this is still only a proof of concept study. We were also able to demonstrate that those patients that benefited the most were those with anterior infarction and those that had occluded vessel on admission to the cath lab, as you can see here. But also notice how small myocardial infarctions are in the non-LAD area when you have an effective primary PCI. It's still a good treatment. But the patients that are most severely affected has the most pronounced benefit of the procedure. We followed up on that, and as you can see here, by 4 years of follow-up, the MACE rate was reduced in the patients that underwent remote ischemic conditioning. But I have to say that the limitation is that this study was not powered for doing clinical outcome studies. And this is why we're now doing the study, the CONDI-2 study, with 4,300 patients, including Asturias in the northern part of Spain. Another important thing that when we looked at the cost and the benefit of the cost, we were able to demonstrate that those patients that benefited were those patients that had heart failure. You can see the reduction here in readmission for heart failure within the first year was pronouncedly reduced in those patients, whereas it declined in the years after that. So it sort of gives a biological meaning, but it's still a proof of concept study. There are now 9 studies out there demonstrating that remote ischemic conditioning might be a way forward, but there are also challenges here, because in another situation where the method was applied to CABG patients with clinical outcome data, the Erik trial and the RIPHART trial, which was published in fall 2015, you can see here that there was absolutely no effect on clinical outcome in patients undergoing CABG surgery. Many of those patients received propofol as the anesthetic regimen, and it's well known that this compound actually have inherent cardioprotective possibilities, so it might interfere with the procedure. Even so, we have to admit that there are challenges when we go from healthy experimental animals to diseased people. When we do remote ischemic conditioning in patients, we do reperfusion to perhaps residual stenosis in contrast to completely normal coronary arteries in healthy experimental animals. We might have microembolization, the area at risk might differ, and the timing might differ. So all these things that I mentioned down here, dose, age, comorbidity, medication, might challenge the efficacy of remote ischemic conditioning. So we've been looking from an experimental point and clinical point on some of these aspects. We have looked at what number of cycles do you need? What should the duration of the cycles be? Should you interfere on one or several limbs? And we use the mice model to do that. And as you can see here, if you have 4 cycles, you will have a complete effect on myocardial infarct size, and it doesn't increase more if you use more cycles. If you have a cycle length of 2 minutes or 5 minutes, it will secure infarct size reduction. Whereas if you continue, at least in a mice, to 10 minutes, it seems as if the efficacy is gone again. So there is a state of too much of a good thing, hyper-conditioning. So we should be aware of that. Also, about the number of limbs. Is it an advantage to take 2 limbs? No, it's not. It's not the amount of the muscle mass that determines the efficacy. What about the timing? We looked at our first Condi trial results and looked in the patients that had a healthcare system delay of below and over 90 minutes, and we actually identified those with long ischemia length as those that benefited the most. And as you can see here, the upward shift of this relation between myocardial salvage and healthcare system delay, it seems as if it might give us an opportunity to extend the window for primary PCI if this is true. Also, the influence of collaterals seems as if those patients with collaterals have the most pronounced benefit of this intervention, and this could even be shown with a sort of dose response efficacy with a Rentrop score down here increasing, whereas those without collaterals didn't have a very pronounced effect. What about the other clinical issues, confounding factors, the cardiovascular risk factors? We looked at that in a post-hoc analysis of our Condi-1 trial, and as you can see here, it seems as if the majority of confounding factors, including age, gender, smoking, body mass index, diabetes, hypertension, and left ventricular hypertrophy, does not interfere except for smoking and left ventricular hypertrophy. You can see that the confidence intervals are wide, and that just indicates that our post-hoc analysis wasn't powered for that sort of analysis, but it points into the right direction. And that also counts for the medication that we used in that trial: beta blockers, ACE inhibitors, AT2 blockers, calcium channel blockers, and statins. It all points in the right direction. So it seems as if even though the patients are medicated on the time when they come in with their STEMI and we do the RIC, they might have a benefit, and it even seems as if they are on statins, they even have a larger benefit by that. Of course, there's one compound that we use nowadays that we haven't taken into consideration, and that would actually be my only concern when we do the Condi-2 study, which is much larger. And this is ticagrelor, as I know you also use here in Spain, and we use it on a routine basis in Denmark for our patients with STEMI and non-STEMI. And ticagrelor has its own adenosine-like effect, and adenosine is actually cardioprotective in large myocardial infarction. So this might be a compound that can interfere with the efficacy of remote ischemic condition in our larger trial. But I think it's fair to conclude now that ischemia reperfusion injury seems to exist in humans, and it appears to be modifiable. There are a number of confounding factors that may influence the efficacy of remote ischemic conditioning. And we don't know yet whether it can be translated into a clinical benefit for the patients. And this is why we do the CONDI2 Erik primary PCI trial in Asturias here in Spain, in Denmark, in Serbia, and in the United Kingdom. And I think that we will have the results in about 2.5 years from now. Recruiting is going very well, not at least because Asturias entered. They have quite a few number of patients. But I also think that we should continue to work about what are the underlying mechanisms. We are not exactly sure what this phenomenon is about, and we need to know more about that to be sure if this is something that our patients can benefit from, so that we can explain what the mechanisms are. That might also give the possibility to develop pharmacological agents that could be used for improving outcome in patients with acute myocardial infarction. So I thank my co-workers, and I thank you for your attention. Thank you very much.
We're going to have time just for a couple of questions. So I would like to start with asking one question to Erik, since his talk was the latest one, and then Tony will ask something to Roberto. So I think there's this extremely interesting, the whole field in general. And also I'm extremely intrigued about the results that you have shown about the interaction between time of intervention and the effect on myocardial salvage. Because as you know, we have seen exactly the same effect in the METOCAR trial or in metoprolol. So in summary, you have seen that he has shown that in patients with the system delay is too short, there is not big effect of remote ischemic conditioning in reducing infarct size. So those patients recruited close to the hospital or even in the cath lab, if you start with remote ischemic conditioning, doesn't seem to have a huge effect. And on the contrary, if you start with the remote ischemic conditioning far away from the hospital, when system delays more than 2 hours, there is a huge effect in cardioprotection. And in fact, we have seen the same with metoprolol. If you start with metoprolol in the cath lab, there is no effect at all in infarct size. Well, if you start 1 hour before or even longer, you have a huge effect on infarct size. So my question is a couple. So on one hand, do you think that we are not only targeting reperfusion injury, but also we might be targeting ischemic injury? So by introducing any intervention, remote ischemic conditioning, metoprolol or whatsoever, we're able to reduce the rate of ischemic death? And on the second hand, do you think it would be feasible to do a randomized clinical trial in which you are proposing to extend the 2 hours window suggested by clinical guidelines for thrombolytics versus a primary PCI under the light of these results of these two trials?
This is still working, right? Yeah. I think that when we did our first CONDI trial, we actually allowed extension to 12 hours. So we had the possibility. But as you saw on the curve here, there were actually not many patients that were beyond 2 to 3 hours on admission time. I think there are several things that we need to take into consideration, because we also need to take into consideration when we do the procedure and the delay between finishing the remote ischemic conditioning procedure and doing the revascularization, because there are windows of protection. We have the first window of protection that is in humans, we think it's about 2 hours, and we have the second window of protection, which is after 24 hours, and that is not relevant in acute STEMI therapy. So I think we need to be very careful how to extend the period here. We did a study also in stroke patients undergoing thrombolysis. And in stroke patients undergoing thrombolysis, it's difficult to say precisely when they have their reperfusion, because they go to the CMI unit and then they got their diagnosis confirmed, then they receive the thrombolysis, and then within the next 6, 8, 10 hours, they had the reperfusion. And actually in that study, we didn't find any efficacy of remote ischemic conditioning as CMR data allowed us to. So I think we must be careful when we plan the study, but I think that we will now extend the period for patients undergoing primary PCI, and we will of course also look at that in a larger scale content when we do our analysis of the CONDI2 study. It's a good idea.
Thank you very much. Because we are short of time, I'm going to do one question to Roberto, but my question has three facets. Roberto, three issues. Genetic risk score. Once we have and most of the issues are because as a clinician I want to know what to do. Once we have a genetic risk score, what can a clinician do with that? My first point. My second point, all these genetic studies that you provided appear to be very good to identify new targets. PCSK9 is just a very, very good example of that. Can you provide us a hint of new targets that are going to appear in the near future? And third point, regarding epigenetics that you just showed us just the very, very, very beginning. Is DNA methylation something that we can modulate? Is there anything we can do to control, to limit, to modulate methylation? Is that a pollution issue, tobacco, cholesterol?
Thanks for your questions. Yes, going through the three of them. GRS, what we have or we can do. The GRS is the reports us about or inform us about the genetic load of an individual, a genetic risk load of an individual. And what we think that we have to do is to incorporate this information in the classical risk functions that we are using right now in the clinical setting. And with this information included in the clinical, in the risk functions, we think that, well, there are some data in the literature that demonstrate that the estimation of the probability is better. So this is one thing that we can do. In secondary prevention, we know that it's associated with worse prognosis, but there are no data right now supporting the utility in the clinical setting to reclassify or to improve discrimination of who is going to have a worse or a cardiovascular event in the future or not. So this is the first question. The new targets, well, I think that I show one that I think that is very promising, that is ANGPTL4, that is a gene that is associated with triglycerides, and it's also some genetic variants are associated with lower risk of coronary heart disease. From Mendelian randomization studies, we know that triglycerides are causally associated with coronary heart disease, so a drug targeting triglycerides could be effective to prevent cardiovascular events. So, and these ANGPTL4 antibodies that have been published just 3 weeks ago in the New England are a very promising new target. And from the epigenetics, I think that the epigenetics could provide us with very useful information for knowing better the pathogenic main pathways in coronary heart disease. And with methylation is one of these markers, and we know, for example, that with one of these, just determine the methylation in one locus in the genome, I can say with 97% of accuracy if this individual is a smoker or never a smoker. So it provides us a lot of information about environmental factors, and could be also very useful to determine the exposure to these environmental factors in the future.
Okay, I think we are going to close the session. It has been really a pleasure, especially co-chair this session with Dr. Bayés-Genís, because both of us, we are clinicians, but also we are researchers. Especially for the younger people in the audience, you have to be aware how important is research, because research of today is going to be clinics of the future. So we think that we have seen two great examples in genetics and in cardiac protection, and hopefully this will be incorporated in the clinics in the future. Thank you very much.
Thank you.